these IDE trials give us an insight into the technology and what can be done with it, but the real world data is what makes us hone those technologies even better and make it much more safer and practical.
Welcome to Rhythm Interventions Unplugged, your monthly deep dive into the world of electrophysiology. Join us as we explore the latest research, share clinical insights, and provide practical tips to keep you at the forefront of your field. Now here's your host, the Director of Cardiac Electrophysiology at St. Bernards Medical Center, Dr. Devi Nair.
Hello everyone, and welcome to today's podcast episode. I'm your host, Dr. Devi Nair, Director of Cardiac EP from St. Bernards Medical Center in Arkansas. And today we're diving into one of the most exciting and rapidly evolving areas in cardiac electrophysiology, pulse field ablation or PFA. This novel approach is generating a lot of interest for its potential to change the way we treat atrial fibrillation. But as always, the key lies in understanding the data. To help us unpack the findings, we're joined by two of the leading experts in the field, Professor Julian Chun, a pioneer in ablation techniques, and Professor Boris Schmidt, an expert in translating clinical data into real-world practice. Today, we'll focus on three major trials that are shaping the conversation about pulse field ablation and some additional real-world trials as well. Let's start with the ADVENT trial, which was the cornerstone study comparing PFA with traditional ablation methods such as radiofrequency ablation and cryoballoon ablation. Professor Chun, can you walk us through the key findings of the ADVENT trial? How does PFA stack up against traditional ablation techniques in terms of both efficacy and safety?
Yeah, hello, Devi. Hello, everybody. First of all, thank you very much for having me on this very interesting format, and it's my pleasure to be part of it. And you brought it right to the point. The ADVENT trial was the first randomized study which compared the very well-established and traditional energy sources, radiofrequency current in combination with an high-density or with an 3D mapping system and contact force information, along with cryoballoon ablation on the cryo on the thermal side versus electroporation using the FARAPulse device, which allows pulmonary vein isolation using pulse field electroporation as an over-the-wire single-shot device. And the big and interesting question was, how would those competitors, thermal energy sources versus non-thermal energy ablation, behave basically in a randomized setting? And in paroxysmal atrial fibrillation in North American United States centers, it came out that the primary efficacy after 1 year with regards to sinus rhythm, there was no difference. Keeping in mind that most operators for the novel device, the FARAPulse device, obviously had very limited experience so far because it was so new and so fresh, but still could get to the same rate of sinus rhythm as compared to the very well-established energy sources, cryoballoon and contact force radiofrequency current. So it was met its non-inferiority endpoint, and therefore it was already a pretty good initial success for the new energy source pulse field ablation using the FARAPulse device. On the other hand, and I think at least from my perspective, Devi, Boris, I don't know how you see it, the safety promise is the very, very big promise when we speak about the all the excitement of electroporation, because it should be non-thermal, and therefore it should not create or fear complications, which are, for instance, fistulas, atrioesophageal fistula, or maybe phrenic nerve palsies or PV stenosis. And I think this is maybe even more important on the safety side. It also could really keep its promise, because in ADVENT, it could be demonstrated it was very, very safe with regards to those complications I just mentioned. However, it was observed there was also, of course, a little bit below 1% rate of cardiac tamponade. And this was, I think, is very well explained due to the nature of its over-the-wire and initial, let's say, initial wire versions are not the ones we are using today. And therefore, mechanical perforations was an issue. But I think this is, of course, well explained due to the, let's say, device design and also the experience of operators, which, of course, had to run or get through their individual learning curves. And maybe later on, we will have the chance to discuss how this developed over time. So I think in the end, Advent proved, from my perspective, it is at least as efficient as thermal energy sources, even in unexperienced hands with regards to sinus rhythm. Procedure times can be very, very fast using the electroporation device, and the safety profile with regards to non-thermal to thermal complications is very, very good. And again, also this is part of the Advent. It was maybe underestimated, but for the thermal ablation, of course, as you know, Devi, there was phrenic nerve pacing, there was esophageal deviation performed. So a lot of measures in order to get to this admittedly very good safety profile also in the thermal ablation arm.
Well, to our listeners, that was Advent decoded at its best. Thank you, Julian. Next, we have the Pulsed AF trial. It was another pivotal study that looked at another catheter that evaluated the effectiveness of PFA in a kind of a broader patient population. And I think this trial, to me, extended the understanding of PFA's potential, particularly in terms of, say, procedural efficiency and long-term outcomes. So, Professor Schmidt, what would you say were the significant outcomes from the Pulsed AF trial, and how do you see these findings contributing to our understanding of PFA's role in treating AF patients, especially in different patient populations?
Yeah, hello, Devi. Thanks for inviting and having me here in this podcast. It's a pleasure to be here with you. And I do have the absolutely same opinion as you. It is another very important piece in the puzzle of understanding pulsed field ablation for patients with atrial fibrillation. So the Pulsed AF study did not only enroll patients with paroxysmal atrial fibrillation, but also persistent atrial fibrillation. In total, I think there were 300 patients, 150 in each cohort, that were treated in a single arm fashion and then followed up very meticulously. So we're talking about patients who were had symptomatic AF despite treatment, so drug refractory atrial fibrillation, not first line treatment, and those patients were assigned to the procedure and then followed very meticulously using transtelephonic monitoring. So weekly transmission of ECGs. So we had a very close eye on the recurrence rate and the recurrence pattern of these patients. And as expected, let's start with the follow-up data. The patients with paroxysmal atrial fibrillation did a little better. They had a freedom from atrial fibrillation of 66%, and in the persistent arm, the freedom from AF was 55%. Both, I think, very consistent, or data that is very consistent with previous reports of thermal ablation, but also consistent with the results that Julian just presented from the Advent trial. Despite the fact that the system operates a little differently, we also have an over-the-wire device, a multipolar catheter, which is, let's say, designed in a circular fashion and navigated to the individual pulmonary veins. And then energy application is in a bipolar PF fashion. And the amplitude here is a little different. So the recipe of energy delivery is a little different from the Advent, the FARAPulse system. Here we're using 3 kilovolts, up to 3 kilovolts of amplitude to amplitude measurement. I think operators were asked to apply at least 4 applications per PV. And in fact, that resulted in a total number of applications, or a mean total number of applications of around 50 applications per patient. Procedure times are very similar. So left atrial dwell time in the range of an hour or so, more or less. The protocol included waiting and testing for exit block, et cetera, et cetera. So the total procedure times were roughly 2 hours, which is still fine for an AF ablation procedure. What is, for me, the most striking finding is certainly the safety profile. So there were only 2 serious adverse events in the whole study. One in the paroxysmal cohort, I think it was a TIA, and one in the persistent cohort where they had a pericardial tamponade. Might be the other way around. I don't recall it exactly, but only 2 serious complications in 300 patients that underwent ablation. This is very, very striking, and I think this highlights what or underscores what Julian just said, that probably the safety aspect of pulse field will be the major discriminator from thermal ablation modalities.
Ready to elevate your skills in electrophysiology and cardiac rhythm management? Don't miss Rhythm Interventions Online 2024. Engage with top experts, discover the latest advancements, and network with peers from around the globe. RIO is hosted by Dr. Devi Nair, course director and host of the Rhythm Interventions Unplugged podcast. This is your chance to ask questions, gain new insights, and deepen your expertise. Our world-class faculty will be live from November 20th to 23rd. Register now for free at riocongress.com.
Well, Boris, you nailed it on the spot. I think for an elective procedure such as AF ablation, I think safety is paramount when it comes to taking care of these patients. Now, finally, I think the SPHERE persistent AF trial was another trial that provided important insights into the use of PFA in patients with a completely new patient population, the persistent AF population. Now, this group is known to often present more challenges in treatment. And to me, this trial is particularly relevant in understanding how PFA can be applied in more complex scenarios. Julian, could you elaborate on the results of SPHERE persistent AF trial, and what do these findings tell us about the use of PFA in a persistent AF or LEAP population? And what do you think how it would influence treatment strategies moving forward?
Oh, yeah, absolutely. Also, very exciting news, which we first heard at the late breaker HRS this year in Boston, and it was presented by Elad Anter. And it's multi-center, prospective, randomized trials. And as you put it, it's not in paroxysmal, it is in persistent AF patient. And it was randomized, I think a little more than 420-ish something patients using the SPHERE 9 ablation, dual energy ablation catheter in combination with the high-density map of Affera versus our good old contact force CARTO STSF, let's say RF energy technology. And as you put it, persistent atrial fibrillation is the very big challenge for now, but also for the future, because they make up to 30, maybe 50% of our patients with atrial fibrillation, and we don't really know what is the best answer, how to address those patients. And what came out in this study, comparing both technologies, again, PFA versus radiofrequency current ablation in combination with contact force, of course, it came out that success rates after 1 year were, numerically different. To best of my memory, it was something around 74% success rate for the PFA energy source for the SPHERE 9 catheter versus 65% for the contact force RF catheter. So you can do pretty good. And I think this is one message, even with RF, but you can do a little better, maybe, if PFA was added as an energy source to this challenging patient cohort. PV isolation was obtained in all of those patients, and operators were allowed, of course, to do more than PVI. It was left to the operator in the end. And if I remember well, posterior wall ablation was very often performed if the patients were randomized to the Sphere 9 catheter. So in the end, there was a numerically better outcome for the PFA catheter, which did not meet superiority. Very, very little difference, but it did not meet it. Maybe if one or more patients were in sinus rhythm after 12 months, it would have been a little different picture. But maybe it's just play by chance. But there is, at least from my perspective, there is some at least light at the end of the tunnel, because we may offer more in the future. We have a different tool in the future which can which we may offer to our patients also to address catheter ablation for persistent atrial fibrillation. And again, the safety. And the safety is, of course, the very, very big point. And here in this trial, also safety profile was very good in both groups. And I think in the PFA group, the ablation profile also was not, or at least it could not demonstrate any signs again for fistula, atrial fistula. There was no patient with a pulmonary vein stenosis. And also, to best of my memory, there was not a high number of cardiac tamponade. I think it was very, very low. So again, in the end, safety profile cross and some promise with regards to sinus rhythm and successful ablation long term in this patient cohort. But of course, as always, we need more data.
I completely agree, Julian. I think we are starting to see that we have a completely brand new technology that's kind of standing almost at par, hand in hand with the traditional tools that we've been using for years, but giving us some additional advantage on the safety aspect. But I think as we discuss these trials, it is crucial to consider how this data translates into real-world practice. And I think we've had significant real-world data come out of Europe between the Manifest registry, the Manifest 17K, and the EUPORIA registry, offering, looking at data. And I think the EUPORIA was about 1,200 patients, and Manifest was about 1,700 patients, and the Manifest 17K about 17,000 patients. All of these registries offering valuable insights, documenting the outcomes with PFA across several high-volume centers in Europe. Professor Schmidt, as the lead author in EUPORIA and as a co-author in the Manifest trials, how do these real-world outcomes from the registries compare to the results we've seen with, Advent and pulsed AF and Sphere persistent AF? And what do you think are the implications for clinicians considering PFA as a treatment option as you've had a chance to use these technologies for much longer than we have in the U.S.?
Yeah, once again, I think this is a very good supplement to prospectively randomized studies, because usually in those large prospective randomized studies, only expert centers, expert operators are involved, and the results are very well controlled. Procedures are carried out in a different fashion. And so it is always very exciting to see real-world outcomes and real-world adoption of these new technologies in daily life. And as you pointed out, EUPORIA collected data from 7 centers in Europe, in total 1,233 patients, including 42 operators at different levels in their career. And I think was what we did see, or what we replicated from the randomized trials, is that the safety prevails, and there is no, even in daily and in routine use, we don't see different or more complications than in these randomized controlled trials. The outcome also is very, very good. Of course, the mode of follow-up is a little different. We did not, in daily life, you do not use transtelephonic monitoring or even continuous monitoring with ILRs, but you do Holters at several stages during follow-up. But I guess that most of these studies also catch the symptomatic AF patients, because these usually return to their ablation facilities to get a redo or treatment suggestions. And Well, what it turned out in both, in Manifest as well as EUPORIA, that for paroxysmal AF patients with a single procedure, we get success rates of around 80% with the single procedure during the first year. In those patients with persistent AF, it's a little less. It was in the range of 66%, but still very acceptable. When you look into procedural aspects of the FARAPULSE procedures, we learned that in Europe, 80% of these cases are carried out without general anesthesia. So using deep sedation with propofol and fentanyl as an analgesic. And obviously, this can be carried out safely. And usually it's not, it's more or less the legal situation in the respective geography that drives the mode of anesthesia rather than the feasibility of the procedure. So that is one finding. The second finding is that data is very early on. It was collected amongst the first wave of operators in Europe after CE mark. And at that time, at that stage, the catheter was not fully integrated into 3D mapping systems. And actually only 30% of the cases were performed together with 3D mapping systems, very differently from Advent and Pulse Select, where more than 90% were carried out in a 3D environment. So obviously, these we didn't see any differences in outcome except for fluoroscopically guided procedures being faster than the ones that were done in the 3D environment. But in terms of safety and efficacy, there was no difference. So that gives us a good, let's say, hint that if you wanted to, you could perform this procedure also in a purely fluoroscopic environment and still be safe and effective. What else? I think you asked specifically for the Manifest 17K data. I find that publication particularly interesting because it also shows you some evolution of the way people are doing the procedures. So the early Manifest data and also the EUPORIA data, we still had 1% cardiac perforations, mainly caused by a stiff guide wire without a J-tip and also by a RV backup pacing catheters. And these learnings led to changes in case management, changing the guide wires, getting rid of RV backup pacing catheters, using atropine instead to mitigate bradycardia after energy delivery. And this actually resulted in a perforation rate or a tamponade rate of 0.3% in Manifest 17K. So much, much less, once again highlighting the safety of this technology.
Boris, I think you nailed it on this one. I think, these IDE trials give us an insight into the technology and what can be done with it. But the real world data is what makes us hone those technologies even better and make it much more safer and practical. So thank you for bringing that data to the world, is what I would say. Having said that, the Heart Rhythm Society's 2024 conference highlighted several advancements in PFA technology, including innovations in, say, catheter design and delivery systems, and again, enhancing the safety and efficacy of this technique. And looking ahead, it is clear to me that that PFA has the potential to significantly impact the landscape of AF treatment, but I think there are still many questions to be answered. Like you said, long-term data, patient selection criteria and integration into other treatment modalities are some of the things. Julian, what do you see as the next steps for PFA research, and what additional data and studies do we need to fully establish PFA's role in treating AF?
Yeah, absolutely. I think as you all put it, and it's a beautiful summary so far, but what's next? What do we need in future? And I think also the door was opened in the SPHERE study, for instance, because as I mentioned before, non-PVI linear lesions were deployed. And we all know that PVI is great and we can do it, and it's the major step probably. But beyond the PVs, it is unclear. And as I said, posterior wall isolation or box isolation was part of the game very often in more than 90% of the patients in the for the PF arm, whereas it was lower in the RF arm. So this could contribute, and we need to, of course, understand which lesions are relevant lesions, what sides do we need to ablate beyond the palmar veins, but also we also need to, I think, better understand, let's say, the dosing thing about PF, because nowadays with heart pumps, for instance, there's a recipe. We all follow a certain recipe. We do those 8 applications, but maybe it is too much. Maybe it is not enough. Maybe we need to individualize. Maybe we need a little more. So I think this is another very, very big chapter of finding the perfect amount of energy to deploy into the tissue in order to get a permanent, durable lesion with a single procedure. But of course, and I leave this to Boris, of course, there will be different catheters, image integration, etc. A bunch of different things, of course, we may think of. But for me, because you asked me, it is about what sides to ablate beyond PV and what is the perfect amount of energy.
Thanks, Julian. And Boris, how do you envision the future? I mean, do you see PFA eventually becoming the standard of care? And what do you think it's going to serve as a complementary approach alongside traditional methods? And just for our listeners, electrophysiologists and other clinicians, what advice would you give them when it comes to decoding and applying this PFA data in their clinical practice? So just to summarize, what do you think they should be looking at?
Yeah, that is a very, very important questions, Devi. And let's start with that one. So most of the studies that we were talking about here, except for the Sphere 9 study, we're dealing with pulmonary vein isolation as an ablation strategy for both paroxysmal and persistent AF patients. And I think that is certainly, or for now, it is the only class 1 recommended ablation strategy and an AF ablation procedure. But for many, many years, we've been carrying out different studies, looking into different ablation strategies, different ablation sets, potentially improving our results with especially with persistent AF patients. And I think this is certainly now we will be facing an era where we will be repeating all these studies, looking into PVI plus ablation using PF ablation catheters to eventually improve outcomes for our patients. And maybe at one point in time, there will be more than just one ablation strategy that is recommended with a level 1 recommendation. For that, I think Julian pointed it out. I think there need to be more technical advancements in terms of understanding the PF lesion a little better. So far, with current technology, we don't have good pre-ablation markers that tell us, hey, this is now the perfect spot with your catheter, perfect contact, whatever, deliver the energy. And also we are lacking post-ablation markers, such as impedance changes, such as ablation index, and all these different markers that we were used to when using thermal ablation. So I think that also translates, of course, into dosing, as Julian said, and to even improve our durability rates, both for PVI as well as linear lesions. And then the next level, I think we pointed all out that the technologies are so easy to use and also very safe in the right hands. So I think this has the potential to change AF patient management. So do we even need to advance our recommendation for an ablation to an earlier stage in the disease process, leave out all the antiarrhythmic drugs, maybe even ablate patients presenting to the emergency room immediately rather than doing electrical cardioversion, rate control, etc., etc. This is just speculation, of course, for future studies, but this is certainly something that could happen. And at the very last level, I would also like to say that we are only talking about the atrium right now. We don't know much about the ventricles, and maybe at one point in time we can even take it there downstairs and get better results on the ventricular level.
Thank you, Boris, and thank you, Julian, for sharing your expert insights today. Pulse field ablation is clearly at the forefront of innovation in cardiac electrophysiology, and understanding the data from these key trials is crucial for anyone involved in the treatment of atrial fibrillation. And as Boris said, maybe someday, ventricular tachycardias as well. To our listeners, thank you for joining us. If you found this discussion valuable, please subscribe and leave a review. Tune in next time as we continue to explore the cutting edge of cardiac electrophysiology. Until then, stay informed and stay safe. Thank you.
Thank you, Devi. Goodbye.
That's all for this episode of Rhythm Interventions Unplugged. Never miss a beat. Make sure you subscribe to the podcast and please share your thoughts with a review. We'll be back next month with another episode. Until then, keep the rhythm going.